See,
Okay. So,
we have today is Dr. Hannah Shaw with us, and she's going to present a case of history of a case which has difficulty in solving. Yes, ma'am, please.
okay. 75 years old female, Fatma, widower for the last 30 years with no formal education, presented from Murray through OPD on 27th of January 2022 with chief complaint of difficulty in swallowing for the last 6 months. According to the attendant of my patient, she was in usual state of health 6 months ago when she started complaining of sticking up of food in her upper chest. Initially, it was too solid, and it was gradual, and it was progressive, and then to semi-solids about 2 months back. And for the last 1 month, she is complaining of difficulty even to the liquid food as well whenever taken in larger bulk. But however, she is able to take small sips of the liquid food for the last 1 month. It was not associated with pain or fever or any sort of lung formation. However, at times it is associated with regurgitation of the same amount of food which she has taken a while ago, with no change in its color, consistency, taste, or smell. According to the patient attendant, she has lost around 10 to 15 kilograms of weight in these last 6 months, but it was not documented according to the attendant. She is not having any history of hypertension, stroke, corrosive ingestion, reflux disease, or dyspepsia, belching, or any type of radiation previously. um, she is addicted to Naswar. Other than that, there is no history of addiction as well. Systemic review is unremarkable with no recent headaches, vomiting, blurring of vision, or chest pain, cough, or dyspepsia, jaundice, etc. Or jaundice. Okay. No previous workup has been done for this problem, and she is here for the first time for her problem to be sorted out. Personal history on her sleep is normal. No, she is having no known allergies. Vaccination has not been done for COVID, and she is postmenopausal for around 25 years. Past history was positive for pulmonary tuberculosis. 2 years back, she developed pulmonary tuberculosis and she took 9 months of anti-tuberculous drugs, and afterwards she was tested negative for this. She had her teeth extraction. All of her teeth were extracted because, according to the attendant, who was her daughter, she said that there was pain in her teeth, so she had to remove that 10 to 12 years ago, and these are being replaced with artificial dentures. Family history is positive for diabetes mellitus, and her husband, according to the attendant, her husband died of cancer, but they don't know about the type of the cancer, and it was around 25 years ago. And according to the attendant, she said that the patient's husband was having a hematemesis, like bloody vomiting, and it was some sort of abdominal cancer. They don't exactly know the details of that. The patient's sister was HCV positive 26 years back. Other than that, family history is negative for any type of carcinomas. Her socioeconomic history is poor. She has one daughter and one son, and son is earning for the sole earner of the family. Okay.
Examination. History is finished.
Yes, the history is finished. On examination, my patient is old lady, well oriented in time, place, in person, sitting comfortably in chair, with no clubbing. Chylonychia, leukonychia was there, but muscle wastage with guttering of intermetacarpal spaces was there. Her BP was 140/90, heart rate was 72 per minute, and her temperature was 98 degree Fahrenheit. No jaundice, anemia, or thyroid was not visible or palpable. No cervical lymphadenopathy was there. Ear, nose, and throat examination was normal. And on abdominal examination, abdomen was scaphoid with slight fullness in her epigastric area, with no scar markings, and laxity of the skin was there. Cuff impulse, upon cuffing, cuff sign was negative. Harness sign was negative also. Palpation showed no visceromegaly. 8 centimeters of liver span was 8 centimeters. And a resonant percussion all over with no shifting dullness, and a ball sounds was positive, and no digital rectal examination was also normal. Chest was clear bilaterally, no spine tenderness, musculoskeletal and nervous neurological examination was also normal. Her mid-arc circumference bilaterally was 20 centimeters, and I did her weight, it was 45 kilograms, and height was 155 centimeters. So her BMI at that time was 18.75 centimeters. Heart also showed no added sounds, and pulse was also regular and good volume. So my examination is also done.
Okay, thank you very much. I think it's a fairly good history and examination, the findings you told us. So let me start with some basic questions before I proceed on this thing.
Okay, sir.
So I'm going to come to your diagnosis and provisional diagnosis after some time.
Okay, sir. Okay, sir.
You said that this patient had regurgitation.
Yes, sir.
Why do you say she does not have vomiting?
Sir, because it was not associated with any type of force she has to use any abdominal muscles. Like it was effortless. The food would come effortlessly to her mouth. And
Okay, so that's the basic concept between vomiting and regurgitation. Because in regurgitations, force is not required and the food substance spontaneously comes out of the mouth. And if
yes,
one observing the act, then obviously one can see in vomiting abdominal muscles being contracted, whereas in regurgitation, that thing will not occur. In regurgitation, patient may not be aware, and suddenly something comes in his throat. So that is right.
sir.
My second question is, which I would like to ask you, you said on clinical examination, patient does not have had jaundice or anemia. How did you know that?
Sir, by examination of her sclera and conjunctiva.
Okay.
On that basis, like clinically, it was not there. And also we can see the palate, oral mucosa.
Very true. Why I brought this point is jaundice and anemia, are they biochemical diagnosis or clinical diagnosis?
Sir, clinically it was not present, but for confirmation, of course, we will do investigations, biochemical investigations.
My question still stands. Is jaundice and anemia biochemical diagnosis or clinical diagnosis?
So biochemical.
Because you define jaundice as this much bilirubin. You defined anemia as hemoglobin less than this. So therefore, history that you can comment upon is differently. In history, you can say this thing, the patient has either yellow coloration of eyes or yellow coloration of sclera, and patient conjunctiva in the eye are pale, the heart palate is pale, the arms look pale. So clinical findings, that is a separate thing that they have jaundice. Now, when you're presenting history, then use like this. That is a separate issue. Again, as you were talking, if somebody says, summarize the case, on that you can such words, technical words, because now you're summarizing a thing in your own words. What you feel like. It's a small point, but one should know this thing.
Yes, sir.
Did this patient had mass in the abdomen?
No, sir.
Then
no mass was not.
Then why did you do the Carnot sign?
Sir, there was fullness in the epigastric area, so to rule out that, Otherwise, there was nothing.
To do a carnot
And
sign.
as a part of my examination as well, abdominal examination, we do it, and as a step of that.
That is a good explanation if you say it's a part of the examination. Because
Okay.
carnot test, you are saying bulge, so bulge you thought could be a mass, so mass you did a carnot sign.
Yes.
But carnot sign must be done if there is a mass in the abdomen.
Okay, sir.
That is correct. You did a rectal examination.
Yes, sir.
And why did you not do a vaginal examination? She was a female.
Yes, sir. I should have done it.
Sahi. Then possibly you told right BMI is 18.75, but
Yes.
in the flow of statement you use the word centimeter. Is BMI calculated in centimeter?
Sir, actually, I calculated that in centimeters,
Hmm.
and it is converted then into meters, which was 1.55 meters.
That is the height you're talking about. BMI doesn't have a unit.
Okay. Okay. Yes, sir.
BMI does not have a unit.
Kilograms per centimeter per meter squares.
BMI was 18.75.
Oh, yes, sir. Yes, sir.
A very minor point. It's not a significant point, but just for the sake of
Yes, sir. So, yes, sir.
Now we come to dysphagia. Now, whenever a dysphagia comes, when you're suspecting that somebody has a dysphagia, the important thing is now the data has come to you. So the thought process is always like this. There are certain questions which comes in the mind and they are to be answered.
Yes, sir.
Let me revise for you those questions, and then I'm going to ask the question in the same sequence. Now, the first would be, if somebody has a dysphagia, then somebody has a disease of esophagus. If somebody has a disease of esophagus, then that could be either because of a mechanical obstruction, or there is no mechanical obstruction, there is an esophageal motility disorder. It means because of motility disorder, the food doesn't go and one experiences. The first question would probably be, does the patient has an esophageal motility disorder or mechanical obstruction? So the questions are going to be around that.
Okay, sir.
Now, if you determine this thing, it is a motility disorder, then obviously the other question will start is motility, which type of motility disorder? So discussion is going to be that on that. It is ecclesiocardia or presbyophagus, whatever it is. And in case if it is a mechanical obstruction, then the discussion would be, is the cause of mechanical obstruction benign or malignant?
Yes, sir.
Once you have done questioning, these have been done, and now we are talking about in terms of operations, then the questions would be, okay, you what is the treatment? And if you say operation, then the question would be about the fitness. Is the patient fit for operation? And then if it is a tumor, then is tumor resectable or not resectable? Is the patient operable or inoperable? And in this patient, if it is resectable, then either curative resection is possible or palliative resection is possible. And as these discussions we go along, then it will end up into, if patient is unfit for operation or section is not possible, then how we are going to palliate and make the patient comfortable. This is a general line of argumentations through which a case of any case, or especially if we are talking about dysphagia, the things will progress. So let me start with that.
Okay, sir.
What I'm going to start with that is, my first question is, what is your diagnosis?
Okay. My diagnosis on the basis of my clinical history and examination is carcinoma of the esophagus.
Okay. And why do you say it's carcinoma esophagus?
Because it is a mechanical type of obstruction which is progressive into the solids, and age of the patient also. And as she is from Murray, they used to cook on wood, so a risk factor has also been present. So that's why.
This is a good answer. What I'm doing is I'm revising the knowledge along with it. I'm asking you a question.
Yes, sir.
As she has told us that dysphagia, if it is occurring in elderly, it is initiate to solids, it is progressive, and then obviously from solid to semi-solid then liquid, then that is a mechanical. But if dysphagia is in young patient and it is both to solids and liquids, it is intermittent, and one also observes there's a history of it is affected by variation in weather, it is affected by the stress level in the person, environmental factors, then that is an esophageal motility disorder.
Yes, sir.
Okay, Doctor, if you say it's a carcinoma of the esophagus, which part of esophagus this carcinoma would be involving?
Okay, sir. Most probably it is the lower esophagus.
And why do you say it's lower esophagus?
Okay. Lower third of the esophagus, because it is more common as compared to the upper two, and it is associated with food regurgitation as well. Sir, I can't think of any other reason.
Did the patient point out any site where she thinks the food gets stuck?
So the chest.
Any
She
part of the
pointed
chest?
towards the chest.
Any part of the chest?
Sir, middle chest.
Middle chest.
Mid of the sternum.
So you can say this thing also. This is also a point जो आपने बताया in addition to this thing. Because when you took the history, the patient said that she feels dysphagia and she was pointing into lower part of the chest. So that is the same portion, not the upper part.
Okay, sir.
And other things which you have told is the commonest site, and there's a regurgitation. So therefore, it is something like this. So these points will cover that. Why you're thinking of carcinoma? Why can't be benign structure?
So because benign structure is more common, in elderly lady, benign cause is, I guess it will be presented earlier as compared to her age. And secondly, she doesn't have any history of reflux disease, gastroesophageal reflux disease, corrosive ingestion, instrumentation. So that's why. Like if it was congenital, like Schatzki's ring, it should have presented earlier, quite earlier, as compared to 75 years of age. And if it is secondary to some risk factors which are not present in her. So that's why I didn't say stricture.
Very true. And that is a good answer, because you have told the patient is elderly. And one thing possibly, an important point is, one can also include in argument is there is a significant history of weight loss and weakness.
Yes, sir.
That can also come. And that's okay. And you have told about benign, you have enumerated the causes of benign. This is a prolonged acid reflux, instrumentation, corrosive ingestion, and these things. That is good. Okay. So your diagnosis is carcinoma. Now I am just on the basis of history and this thing, I am arguing. I'm not further going this thing.
Yes, sir.
What do you, how do you think patient is fit for operation clinically?
Clinically, the patient is like on ECOG scale. When I asked the patient about her, she is able to do her own chores. Like she is able to do self-care. And as she was sitting there and she was like her mobility within the room was good. Like I think she is clinically, I feel like she is fit for surgery. After nutritional assessment and all that, after building up her nutritional first sort of.
That is correct, because when we're talking about clinically, then we are not talking in terms of scientific parameters which we have to say this thing. But clinically, if patient can do normal course, a patient doesn't get breathlessness and walking, which are the normally how we find if a patient is fit or not, and is not unnecessarily weak, महसूस कर रहा है आदमी, तो on this basis clinically we can say that patient is fit for operation. Do you think that patient is his cancer is what? It is metastatic or not metastatic?
So clinically, I was not able to find any lymph nodes, any mass. Chest was any effusion, like chest was clear bilaterally. No visceromegaly was there. No ascites was there. No bony pains or spine tenderness was there. So I didn't find any point of metastasis. So I think it's not metastasized.
Now, if any tumor who is not metastatic, then the question will always come is whether it's an early carcinoma or whether it's an advanced carcinoma. So clinically, the information which you have, is it an early carcinoma or it's an advanced carcinoma of the esophagus?
Sir, if it is causing like obstruction to the liquids also, so I guess it is locally advanced.
It will be locally advanced. So this lady is locally advanced.
I guess, sir, clinically.
Bilkul sahi. Well, it is your opinion that patient is, since it's liquid also, and so it is locally advanced. This is good. You see, what you're doing is, in fact, you are applying the knowledge on this patient. Now, that is important to understand. Whatever you're talking, at the back of the mind, you are bringing in the relevant knowledge, and then the patient.
Okay, sir.
So now let's go. Now we are going to start on the next step, and which is the investigations and the treatments. What I'm going to do is, I'm going to stop the recording. So first segment of history taking is finished, which is history taking and examination. And we will continue from investigation onwards. So join me again.